The next lecture in this session, Dr. Talal will talk about. Dr. Talal Taweel is a gastroenterologist. He's the head of the gastrointestinal section in Jabir Al Ahmed Hospital in Kuwait. He will talk about acute severe ulcerative colitis beyond salvage therapy. Dr. Talal.
Bismillah, salatu salam rasulullah. Thank you, Uthman, for the introduction. So the topic that I've been assigned is really to, in 20 minutes or so, talk to you about the sort of latest updates in acute severe ulcerative colitis. So these are my disclosures. So I've tried to be inclusive, and a lot of the recommendations or data I've been putting will be from both the European and North American guidelines. So the ECHO, a bit from the BSG, and also from the AJ. Sorry, Dr. Marshall Beaton's publication from 2012 needs a bit of updating, so I haven't included it yet. It was in my previous presentation, but I omitted it this time. So the acute severe UC really is a different beast, really, and has own unique algorithm, and really behaves differently to the the ambulatory patients with ulcerative colitis, and the incidence ranges from around 8 to 20 per 100,000 person years, and at least up to a quarter of our patients will experience an episode of acute severe UC. And out of this 25%, up to a third will undergo a colectomy, whether in the same inpatient admission or electively down the line. And the mortality of acute severe ulcerative colitis was very high in the past. Up to a quarter of these patients died. With the introduction of steroids the last century, it came down to 7%, and then with expert surgical input, it's down to around 1%, which is around the risk of a coronary artery bypass graft. So it's not an insignificant risk, this 1%. And to be using a criteria that's 70-year-old up until 2025, I think just gives credit to True Love and Wit, really how robust their data was, that we're still using it in 2025. So the criteria we use is basically for acute severe UC is this. So if you have you need to have 6 or more blood emotions and one criterion of a systemic inflammatory response syndrome, so either a tachycardia, temperature, hemoglobin. They actually had an ESR. There was no CRP at that time in the 50s, so it was adapted now. I don't think anyone uses ESR anymore, so it's been replaced with a CRP. So if you have 6 bloody malmotions and one of those, then you have acute severe ulcerative colitis. And why is that important? Because if a patient does fulfill that criteria, that patient should be really admitted to the hospital for inpatient management. Now, just for residents, just make sure you get your stool infectious workup sent off immediately. So you want to send off the usual microscopy and culture, but most importantly, you need to get that C. diff sent, because that's a reversible cause that we'll talk about that has an impact on their prognosis. In terms of stool for parasites and ova, it's not really recommended unless the patient has traveled somewhere endemic. Well, in our region, there are regions around us that are endemic, so just always take a travel history for those patients. Apologies. So with C. diff, I think now we know that IBD now is an independent risk factor for Clostridium difficile, so you no longer need antibiotics for that. And the problem is when you diagnose, it's associated with a longer hospitalization and a higher mortality. And what's really worrisome is that the risk of colectomy really shoots up to around 6-fold if they have C. diff. And we said 60% of our patients don't have a history of antibiotic use, so you really should get that C. diff checked, and because we have effective treatments now for the treatment of C. diff. Imaging, so we don't really need much in the way of imaging initially when these patients are admitted. A plain X-ray usually suffices, and that's just to detect sort of complications more prognostically, and to know when you want to get the surgeons involved. And what you're looking for is colonic dilatation and the presence of mucosal islands, as you can see here on the left. You can see what's called the thumb printing, and then on your right-hand side, you see sort of the dilatation there in the transverse colon. And that's obviously a very worrisome sign, and you need to get the surgeon involved early. So with acute severe ulcerative colitis, so this is not the time to show off your endoscopic skills. All you need to do really is do a quick flexig in and out, unprepped or just with a couple of enemas. And the real reason is to confirm endoscopic severity, that actually have acute severe ulcerative colitis, not another cause. You want to look for pseudomembranes for C. diff, and also importantly to look for CMV. So you might want, in some centers, might do sometimes a second flexig after the patients, they're not doing very well, especially when they're on steroids, to check for CMV and non-responders, but you usually do the flexig within, the initial one within 24 hours. I know I said a flexig is enough. You don't need a full colonoscopy because of the increased risk of a perforation. So nutrition, a lot of people, especially the surgeons, are tempted to keep these patients NPO and put them on TPNs. However, there's no real good evidence to support that, and maybe there's evidence to support that there's increased complications with TPN. Remember, these patients are immune suppressed on combination therapy with immunomodulators, even combination biologics sometimes, and they're at really risk of infection from the lines. And TPN might be detrimental in basically deriving the enterocytes of their short chain fatty acids. So it might be used as an adjunct in patients that are going for impending surgery, but in all the other patients you should go really for normal or enteral nutrition. I personally give them a low residue lactose-free diet, not because it gets them any better, just not to confuse me that if they're lactose intolerant, they might get a bit of diarrhea or from the high residue. So I keep them on low residue lactose-free just to make sure I can really monitor the diarrhea and the response to treatment and not have any confounders. This is extremely important. It's very easy, but it's easy also to miss, and it has very big consequences and possible litigation if you don't put the patients on VTE prophylaxis. So our patients are at high risk of developing up to 3.5 times risk of developing a venous thromboembolism, and once they get one, they're at double the risk of mortality once they get one. So, and we know that the higher VTE risk is associated with a more extensive disease extent and severity. And there's really, we try to reassure our internal medicine colleagues that there's really no increased risk of rectal bleeding when this is a prophylactic dose. We're not giving them therapeutic enoxaparin. It's a prophylactic dose, so it's very safe. So make sure all your patients are on low molecular weight heparin. Narcotics, so this is a very painful condition, obviously. So these patients are in pain, and it's part of our duties as physicians to be humane and alleviate our suffering. That's what we, in our oath. So, but you have to use the right agent. So we know that narcotics can lead to the development of toxic megacolon. You try to have judicious use of narcotics. Now we have access to IV paracetamol in our region, which is actually quite effective in our patients. So maybe we can use that. And if not, obviously you do give them narcotic, but really on a as required basis. So there's no role for antibiotics except there is obvious infection or sepsis, or there is a confirmed C. difficile infection, but it's been shown that there is no data to support routine use of antibiotics in patients with acute severe ulcerative colitis. So we come to steroids, which are really the mainstay first-line treatments for these people, and it should be really IV steroids. They're the most effective first-line therapy, and everyone should be on IV steroids with pretty high. Most patients do well actually with steroids, up to 70% remission rate. And there is really, this is not the time to discuss which type of steroid. Just see what your institution gives and just give it. Just make sure you know your dose equivalence and you're giving the right dose of steroids. So we don't need to give what our colleagues in rheumatology give, these pulses of 500 mg or 1 gram of methylpred. So there's no data to support that. So we just give the equivalent of either 60 milligram of methylprednisolone or 400 of hydrocortisone. There's really no difference between which one you choose, as long as you give the right dose. So steroid failure, really you should have a system of assessing these patients objectively. So really you should do your assessment after 72 hours to assess for steroid failure and use an objective score. So the simple, and there's a few scores. The Oxford one by Simon Travis's group is pretty simple and good one. where basically if at day 3 they have 3 to 8 bloody bowel motions with a high CRP or just more than 8 bloody bowel motions, then the risk of colectomy is 85% without second-line therapy. So that's an indication to start a second line. There's also other ones like the Ho index, which is a cumulative point-based score, and the higher the score, the higher the chance of steroid failure. So our traditional second-line therapy, I'll borrow a phrase from my previous speaker, Dr. Shaji, about the king of the hill. I think the king of the hill here is anti-TNF, really, especially infliximab. Well, we'll speak about IV cyclosporin. There shouldn't be, your traditional second-line therapies are infliximab, IV cyclosporin, or colectomy, and there's no role for any other anti-TNF in severe hospitalized UC. We'll speak about other agents later on, but these are sort of the traditional second-line therapies that we use. So this has been studied extensively in terms of the which one is superior, cyclosporin versus infliximab. So there were 2 studies, the CYSIF study published in the Lancet, and then the Construct study, and they both showed that there was the cyclosporin was not more effective than infliximab, and there was no superiority to either agent. I think the Construct study did show that possibly cyclosporin might be a bit cheaper, but in terms of clinical effectiveness, they were similar. Both are similar. So which one should you use, infliximab or cyclosporin? Well, there is no superiority, I said, in short to long-term colectomy rates. Cyclo might be more cost-effective, but then these studies were done before the era of biosimilars, so this might be offset now by the advent of biosimilars. You might want to consider cyclo if there's a previous failure or intolerance to infliximab. And remember, azathioprine experience, you shouldn't be using cyclo. And there are a special group of patients maybe that you want to, with like cholesterol, magnesium, you might want to avoid cyclosporin. So you give your second-line therapy. What do? So you need to assess your patient, right? You should have a timeline. So after 5 to 7 days treatment, you should be reassessing this patient, and it should be resolution, clinical, mainly resolution of abdominal pain, rectal bleeding, and tolerating a diet. If they respond to infliximab, just continue your induction as per the protocol. And if they respond to cyclosporin, you'd be switching to cyclosporin oral, but then you need a maintenance agent. And traditionally, this has been azathioprine, but there is data now to suggest maybe that you can maintain with vedolizumab. There's some observational data shows you that you could maybe use vedolizumab as a maintenance agent instead of azathioprine, which is not an agent that we're using now in this day and age, because to slow efficacy and high sort of adverse events. So the question that we always ask is, maybe if infliximab works, why not give more? And is more infliximab better? So this is a retrospective data from 3 US centers and 213 patients with acute severe UC. And they did a meta-analysis as well as meta-analysis of published study. And as you can see here, there was no real difference in both the inpatient and long-term colectomy rates in both the intensified arm and the standard induction arm. However, among the accelerated dosing arm, there was a low risk of colectomy for those that took an upfront 10 mg per kg compared to those that took a 5 mg per kg chaser dose. So if you're going to give intensified, you might as well give the 10 mg per kg. And this was this is newer data. So actually, I was there for the presentation presented in DDW last year. It was published last year in November in the Lancet Gastrohepatology from an Australian group. So it was an open label. It was only a randomized trial comparing standard induction to intensified therapy in patients with acute severe UC. 13 centers, Australia, IV steroid refractory acute severe UC, randomized to receive a first dose of 10 mg per kg or 5 mg per kg in a 1:2 ratio. It was a bit of a complex design, so you had 3 arms, so standard, intensified, and accelerated, where one of them was the intensified and accelerated, one had a chaser dose and one had a 10 mg per kg. So as you can see here, there was no difference really between the 2 arms, the standard or the intensified, and no difference also in the secondary outcomes of colectomy by day 90. However, the only finding is that what they found is that there's faster improvement in the clinical parameters of and CRP remission in patients who took the intensified arm, but they all catch up at 3 months. So your patients get better a bit quicker, but eventually they all catch up, and they got. Their authors concluded that you might want to consider it in certain sort of sick patients. You might want to consider an intensified regimen, but you're also fine if you use the standard dosing because there's no strong data. It was a negative study really in terms of the primary outcome. So what do you do with non-responders? So patients who don't respond after 3 days of steroids and second-line therapy should be considered for surgery. And we know that there's data to show that delayed surgery in hospitalized patients with acute severe outcomes acute severe UC, is associated with poorer outcomes, higher inpatient complications, and higher inpatient mortality. So what about sequential therapy, meaning that you give infliximab after a cyclo failure or the other way around? So we know that it does work, as you can see here. This is data published in CGN 2008, that it does work. However, the worry is really the adverse events in this group, and this particular cohort from Mount Sinai, they had actually 1 death in a patient with gram-negative sepsis. So and this is just to show you that they actually do have good remission rates with sequential therapy, but then the mortality is quite high in the serious adverse events as well. And the ECHO statement on this is that just to consider it in specialized centers and case-by-case basis. So the new kids on the block now, the JAK inhibitors. So is there any use of them in acute severe UC? So this has started, a lot of work obviously was done. Peter Higgins group in Michigan, they started with a case series, and then they published their retrospective case control study with 40 biologic experienced patients, acute severe UC, that were initiated in TOFA as an inpatient after failing steroids, so not sequential, so just after steroids, matched with controls, and they gave the higher dose of 10 milligram 3 times a day, and they got that from the initial pivotal trial where there was an arm for 10 milligram for tofacitinib in UC, there was an arm for 10 milligram TID, so they actually used the higher dose. And what they found is that there was a difference between the controls and the patients that received TOFA, as you can see on the graph on your left. But when they did the subgroup analysis, this was only significant in the patient that got the higher dose and not the standard dose of 10 milligram BID. So this is actually a study where the author is sitting right across from me. Dr. John Marshall is a senior author in this. This is an ongoing phase 4 trial in Canada for patients with acute severe ulcerative colitis that failed intravenous steroid, and they were treated with 10 milligram BID and not TID. Maybe we'll discuss that in the Q&A with Dr. Marshall about the dosing. It's presented by Neil Agnarola and DDW last year. And this was an interim analysis that presented in DDW, and what they found in patients who received the 10 BID, obviously this patient was pretty sick group, 1/3 actually were TNF failures, and their primary outcome was day 7 clinical response, which was achieved in 58% of the patients. And their colectomy rates were around 16% by day 7 and 25% by 6 months. And they concluded that it seems to be a promising strategy, although they're due to present their full data set later on. So this is the TACO study, which was published in the Red Journal last year. It's only a randomized trial for TOFA and acute severe UC. They randomized patients to placebo versus 10 milligram TID of TOFA for patients who failed IV corticosteroids. The primary endpoint was response by day 7. And there was a clear difference here with a delta around 15% in terms of response between the placebo and the intervention arm, and with a decrease in the need for rescue therapy for the patients who received TOFA compared to the placebo arm. And really you can see sort of the difference quite clearly here, as you can see in the graph between the TOFA and the placebo arms and the need for rescue therapy. So what about UPA? The new kid on the block, if you can use TOFA, is it a class effect? Can you maybe try UPA? Well, there is some data, but it's obviously retrospective. So this is data published in the Red Journal last year. This is a retrospective chart review of 25 patients in 5 US centers. The very sick population, 2/3 were infliximab exposed, and the primary outcome was 90-day colectomy rates. And as you can see, there was no comparative arm. If you look at the doses here, so if they use 30 mg most of them use 30 milligram twice daily. Some of them use variable doses, 45 milligram once daily, which is a slightly different dosing between them. So there was a variety of doses that were used. And the colectomy rates at 90 days were around 24%, which was sort of similar to what John's group, I think, found. So it seems to be promising, very small data, but might be something, an agent that might want to consider. So just to finish up with the algorithm for acute severe, you see, I like the one in the BSG that I've modified slightly. So you get your patient, adult patient with acute severe ulcerative colitis that fulfills the Truelove and Witt criteria. You send off your baseline investigations and the stool infectious workup. You get your sigmoidoscopy done. Make sure your colorectal surgeon is on call and assesses the patient regularly with the regular consultant review by a gastroenterologist. You get your steroids started, whether the hydrocortisone or methylpred, the right doses. And then you assess your patient at day 3, clinically and preferably with an objective score such as the Oxford score. You have a regular surgical review for whether the patient needs a colectomy at day 3. And I think this is, I would maybe consider a JAK here if the patient is infliximab exposed. So this is the patient that comes in, has not responded to steroid. This is a place, maybe a time where you might want to consider a JAK inhibitor. So if the patient doesn't respond, you want to start your second line therapy and then assess them at around day, say 5 to 7. And if they respond to your therapy, then obviously you'd continue. If they don't respond, then you have obviously a very regular surgical review. If they need a colectomy, they go for it. If they do refuse colectomies, which is the case in a lot of our patients here, this is also a time you might want to consider a JAK inhibitor if the patient especially refuses surgery after failing, for example, infliximab. And for your patients that respond to therapy, that you gave cyclosporin, instead of maintaining them on azathioprine, you might want to, there's some data that suggests you might want to maintain them on vedolizumab. And that's it. Thank you very much.